since the time restrictions, we will go to IQ. In my presentation, actually, we know that in our busy clinic and injection clinic, sometimes we need to go a little bit to the basic. So my target of my talk today is to talk a little bit basically about the CRVO. So starting, what should we know about CRVO? I believe the first thing we should know is target. What's our target while dealing with the case of CRVO? And I think this rule should apply not only for CRVO, for our life. Everyone should have his own target. The second point we need to know about is the treatment option we have, and finally the efficacy of the treatment option. So starting with the targets, what should be our target while dealing with the case of CRVO? Should be the macula, or the retina, or the eye, or the patient. Definitely the macula should be one of our main targets, since the macular edema secondary to CRVO is the main cause of visual loss. Retina is another important target also, because we should look for ischemic changes and try to prevent them from occurrence. And we have a fact that non-ischemic CRVO could convert to conversion to ischemic CRVO, and that's why we should follow up the patient occurrence, because we have almost 35% conversion in 3 years according to the Center of Venous Occlusion study, and 15% can occur only in the first 4 months. So follow-up is very important to look for that. And if there is some prognostic factor that can give you an idea about this patient, whether it's ischemic or non-ischemic, presenting visual acuity if the vision is 2400 or less, or rare presence of retinal defect, and finally absence of ocular shunt give the chance to new vessels occur 25 more times those patients will have ocular shunt. Definitely we don't want to miss this for the retina angiography while dealing with the patient. What about the eye? Definitely it should be our target. We need to prevent complication, and if it happens, we need to treat it properly. And the most common complication, as you all know, is vascular glaucoma. So regular follow-up, as I mentioned before, is crucial for this complication. And please don't forget gonioscopy while dealing with the CRVO, because sometimes the new vessels appear in the angle before appearing in the posterior segment. So we should take care of that. As I told you, the ischemic CRVO, 6%, which is a big percentage, develop ocular vascularization, and 10% of the patient can develop any type of RVO, either in the same eye or in the fellow eye. What about the patient? Definitely, one should be our target also, because this patient has systemic disease like hypertension, most commonly hyperlipidemia, and sometimes the RVO may be the presenting sign for this patient. But in bilateral cases and young patient and family history of thromboembolism, I think we need more workup, laboratory workup, to look for that cases. Not like old patients with hypertension, no need to go for extreme or extensive workup. And we all know that about the optimal control of the systemic condition of the patients can really decrease the incidence of the similar occlusion in the fellow eye. So, dealing with the CRVO, I think our targets, if we target the macula, retina, eye, and the patient, if you all this in our scope, I think we will reach the best medical care for the patients. What other treatment options we have? Dr. Rao actually explained it a lot, but I will just focus some point, because that we are still seeing the practice. Do you observe or treat? And if you're going to treat, do you do laser or pharmacotherapy? And if you are going to do pharmacotherapy, which one, anti-VEGF or steroid? Starting with the first option, do you treat or to observe? The fact is, early treatment is better. And we have evidence from the early study about the dexamethasone study and ranibizumab and the ILEA or aflibercept. If you look here, for example, this Geneva trial, we found that those patients who received the treatment early gained visual acuity more than who just started the treatment late after 3 months. What about cruise trial with ranibizumab? Also the same finding. If you look here at the sham arm, he didn't receive any injection. It started for 6 months. And they started to receive the injection started for 6 months. So they delayed for 6 months. If you look at the end of 12 months, those who started treatment early really gain more visual acuity compared to those who started treatment late. The same finding also in the Copernicus trial with aflibercept. You can see here also the difference, big gap between the visual acuity in both groups. So treatment early is most important. So we shouldn't wait, we should treat. The second option, if you're going to treat, you're going to do laser or you do pharmacotherapy, intravitreal pharmacotherapy. Let's look at the evidence. The evidence actually, there is no rule for laser or grid laser in macular edema second CRBO. And the evidence from that, if you remember in 1995, the Center Venous Blood study, they look at that option. But we cannot deny the role of PRP in ischemic cases. Just to refresh our mind, this is the study, the Center Venous Blood study. You can see here the treated and untreated eye, there is no difference in visual acuity for macular grid laser. So, in conclusion of this study, we recommend that not to do or no benefit if you do macular grid and CRVO. So there is no rule for laser, as I mentioned, except for PRP or ischemic cases. We should go for pharmacology. So which one, anti-VEGF or steroid? Actually, this is a debatable topic because you can use both, and I think we need more head-to-head trial to prove that. So I think we can delay to the next meeting since we have more results. The last thing, I think we should the efficacy, and I think Dr. Rao explained that. We all know about the efficacy of steroids, starting from the old SCORE trial, intravenous triamcinolone, ending with the Ozurdex pivotal trial. And you can see here the Ozurdex or dexamethasone implant. Actually, it gave a good visual gain, especially at 3 months, but usually we know that the effect declined by time. And we all know sure about the duration of dexamethasone implant. I don't know the other people do the same. I think it's not last more than 4 to 5 months. It does not last 6 months. This according to my experience. What about anti-VEGF? Ranibizumab, the most commonly used now, and also aflibercept. And we have the trial, just to refresh your mind about that. We have the cruise trial, and definitely, and also Capernaum trial. And this trial actually by far was different, a big difference, and the patient achieved a very good visual gain. This is our Galileo trial for aflibercept also. So in conclusion, I think we should have panoramic approach when dealing with the case of CRV. It's not only the macula or the retina or the eye, the whole, it's a whole package. You have to take care of all this. No role for grid laser again, because we're still seeing some patients doing grid laser for macular edema CRV. So there's no rule for that and no visual gain, except laser only in ischemic cases when you do PRP. Proper follow-up is crucial, and not only proper, it should be long follow-up, because as I mentioned before, we still have a chance for non-ischemic to be ischemic over 3 years. So I think those patients, don't forget them. You have to keep them asking every 4 to 6 months until you make sure that everything is okay. Great treatments reduce the final outcome. As I mentioned before, don't wait. Even any kind of RVO, not only CRVO, even in diabetic, even everything. So early treatment actually give us a very good and sustained outcome. And follow this last thing, if you follow the treatment guidelines, improve the result definitely, and also our real practice give us a good impact. So I think all this trial is just a guideline, because in our real practice we don't have something called exclusion criteria. We have to treat all patients, but in this trial they are having specific exclusion criteria. They include this patient, they discard this patient. So in our real life we don't have this option. So guidelines is important, but our clear clinical practice give us another very good impact. So thank you for your attention.